to you if we're ready. Lauren.
Good afternoon.
Can I take some copies and put it in the box?
Absolutely. Absolutely. Whichever copies you need. My talk today is on mechanical ventilation, and there'll be part 1 today and part 2 on Thursday. We've distributed to all of you, and at least all of you should have, 2 articles, separate articles. One that talks about mechanical ventilation in general, including some of the history, which I'm going to talk to you about. And the second article is something that we're going to address on Thursday, which addresses auto-PEEP, the concept of positive end expiratory pressure, and its effect with mechanical ventilation. The reason for putting this lecture together, I did maybe about 10 years ago, 11 years ago. One of them was because of my own experience as a student and as a resident. I just never understood mechanical ventilation. And so, and many of the lectures that I heard still did not clarify or help me understand the concepts of mechanical ventilation. You don't have to be a pulmonologist or a critical care specialist to understand these concepts and to manage a ventilator. We have some of our own faculty who have privileges for managing both short-term and long-term mechanical ventilators. The scope today will be to talk about mechanical ventilation, but invasive positive pressure mechanical ventilation. I'm going to talk to you about a little bit of the history of mechanical artificial ventilation and how we got to this point. And one of the reasons is because I think if you understand how you get from one point to where you are now, it helps you understand a little bit of the concepts and why we use the different things that we use in mechanical ventilation. I know the terminology is difficult for you right now, especially for the interns and some of our students, but that will all be clarified. And I'm going to reiterate, like I did with my chest x-ray lecture, that the best way to learn mechanical ventilation is to do it, to manage it, to offer yourself. Go out there when you have a patient on a ventilator, try to understand what's going on with the patient, try to understand the physiology. That is, the patient's own physiology. Are they coming in with restrictive lung disease? Are they coming in with obstructive lung disease? A combination of the two. Why are they on a ventilator? Okay, why are they on a ventilator? It's important. So once you can put all those things together, then it helps you understand why changes are made on mechanical ventilation. So the whole scope is to demystify the concept of mechanical ventilation. Artificial ventilation, actually the concept got started as far as back as Aristotle and Socrates and Plato. You can read in some of their own literature describing insufflation of air artificially from one individual into another individual through a hollow reed. So already man had a concept of artificially ventilating, delivering oxygen to another individual. Later on, many thousands of years later, in the Dutch literature, they describe medical students using large bellows that they used to use for stoking fires, okay, and connected to tubes that were inserted into the airway, upper airway of patients. And these students would take shifts and do shifts as part of their rotation. So I'm not a proponent of that, but just to give you an idea that, again, this concept of artificially ventilating individuals has been around for quite some time. So with that, does anyone know or have an idea what time and what event or events occurred around the 1930s, especially 1920s, especially in this country, that got people really thinking, got physicians, scientists thinking about artificial ventilation? Can anyone?
Is it the TV?
No.
There was some diarrheal event.
I'm sorry?
There was some event, diarrheal event, and these medical students even has to artificially do the pumping for a while.
Where was this?
1970.
Well, I'm talking about an epidemic.
Oh, the flu.
What?
Polio?
Exactly, polio. So polio in the 1930s, late 1920s, hit this country pretty hard. I can still talk to my mom about that. She's in her 80s, and she remembers the whole scare of polio and what it did. And often many of these patients developed respiratory insufficiency secondary to neuromuscular problem, and they had trouble ventilating. Okay, so as a result, they came up with what's called the iron lung. Does anyone know what the iron lung is? I had the pleasure, and actually I didn't appreciate it at the time, I do now, of managing a patient for 3 years during my fellowship training. I had one of the only 2 iron lungs in the state of Connecticut, and my patient would go into the iron lung at night, and then she would come out in the day just wearing oxygen, and then would have to go back in at night. And at the time I found it kind of boring and didn't really appreciate how much this could really help me understand lung physiology and how things work and why we do things. But again, as I said earlier, our scope is going to be on invasive positive pressure ventilation. So I want all of you to get an idea of the classification of mechanical ventilation. And we start out again on this side with negative pressure artificial ventilation. And the 3 major ones that we have seen in the past, and on occasion you still may see, are the iron lung, which I just described, the body wrap, and the tortoise shell. Okay, the body wrap is really a tubing that's put around the individual's thorax, and it functions by creating a negative pressure. All of these function by creating a negative pressure around the thorax. And as you recall, and we're going to talk about this a little bit more in detail so you understand better, because if you don't understand these concepts, it's going to be hard for you to understand the concepts that follow about mechanical ventilation. But we breathe right now, as you're breathing tidal volumes of roughly 500 cc's or 500 mLs each breath. You're doing that because of why? Does anyone understand or know why you're able to sit here and watch me and breathe?
Because of negative intrapleural pressure.
Well, yes, and even beyond that, we have a respiratory center, right, in the midbrain, which sends signals down to various areas of the thorax, including as far down to the diaphragm, the extra-respiratory accessory muscles of the sternocleidomastoid muscles, the intercostal muscles, and this allows us to take deep breaths. And the whole concept of inspiration is an active process, right? It's an active process. It's only with our normal elasticity that the lung returns to its natural form and is a passive process. You need to understand that. You need to remember that and just understand that. Well, in the iron lung, they take advantage of this concept by creating negative pressure. All around the body. And when you create a negative pressure, then the positive pressure that is coming through the airway is much easier to allow for expansion. Right? And that's the whole concept of the iron lung negative pressure ventilation. No more, no less. All right? However, although this was innovative and it was very helpful, you can only imagine that it presented still with some unanswered issues, okay? And one of the problems was trying to get to these patients. So if patients had Foley catheters or IVs, you can only imagine that how difficult it was to get to them. Plus, this type of modality, okay, is really only helpful in what type of respiratory insufficiency? Secondary to what? We just discussed it. So any neuromuscular disorder, right? It's a mechanical problem. It's not an intrinsic airway or alveolo-interstitial lung problem or pulmonary vascular problem. It does not act that way. It does not treat that. It does not help that. Okay? So you can understand that scientists, physicians alike, had to move on to a different concept historically. And that's where the whole concept of positive pressure ventilation came about. And that gets subdivided into two categories, and I'll go over these with you. So, when we're talking about positive pressure ventilation, what we're saying is we're introducing into the airway system a positive pressure from the outside. That can be divided into non-invasive positive pressure ventilation, which you already know to be either CPAP, continuous positive airway pressure, meaning that it's giving the same pressure both in inspiration and expiration, or what we call bi-level positive airway pressure, which you can adjust the pressures both in inspiration and in expiration. Okay? With these machines, you can also dial in the FiO2 and the rate. All right? The scope of this discussion will not be focused on non-invasive positive pressure ventilation. The scope of the discussion will be right here. Okay? So, invasive positive pressure ventilation can be divided again into volume cycled, and we're going to discuss what that means, and that's what you see every day. That's who's in the ICU this month. Who was in the ICU last month? You're okay, Nega? And you're okay. So what you saw for most of it, okay, was volume cycled positive pressure ventilation. What do they mean by volume cycled? Volume cycled means just this, that you can set the volume. You have control over the volume, okay, that the patient's going to receive every breath. What you don't have control over is the pressure. And that pressure is determined by many things. By the physiology of the individual, whether they have pre-existing chronic lung disease, whether they have COPD, whether they have restrictive lung disease, such as interstitial lung disease, whether they have pneumonia, whether they have bronchospasm, it can change, okay? Other types of the conventional, that are not conventional, but we still see them and use them, is APRV, which basically is a mode of ventilation that you only use in pure hypoxemia, okay? You do not use it in a patient who has hypoxemia and hypercapnia. And what it basically does is it insufflates the lung, and then on expiration, it comes down very slowly, setting a PEEP that decreases. If you set the PEEP at 15, it goes to 14 for 10 seconds, it goes to 13 for 10 seconds, and it does that. And what it really does is cause recruitment of alveoli. That's a separate discussion that we're going to address on Thursday. But I just wanted to let you know what the APRV signifies and what it means. High-frequency jet ventilation. I grew up using that, if I can use that term. It was invented at Hartford Hospital, where I trained at the University of Connecticut. A guy by the name of Gluck, Dr. Gluck, we used to call it the Gluckulator, came up with this concept. And basically, it got only FDA approval for one entity, and that was for bronchopleural fistulas. So in the setting of bronchopleural fistulas, the high-frequency jet ventilator was used. They no longer make them, but it used to send out very small tidal volumes of maybe 50 cc's. And so in ARDS, it worked very well, even though it wasn't approved for it, and it also worked well in bronchopleural fistulas. We don't use them anymore. We used to be able to use them here, and now they don't make them anymore. The high-frequency jet ventilator was really kind of supplanted, I think, by the APRV, and so you probably won't see it ever again, I don't think. I want all of you to know that although mechanical ventilation is very useful, very helpful, especially when indicated, you need to know that it has never been proven to improve mortality. There are no studies. As you can only imagine, you can't randomize someone to a ventilator and someone to a nasal cannula. It's unethical. Okay, and so that's why when some people say, well, you know, what you're doing, Dr. Lovett, is never been shown to improve mortality. And I say, you're absolutely right. So why don't we stop the ventilator? Just stop it. But nobody has the courage to do it because it's unethical. You understand there are some things you can't do. Double-blinded randomized trials, prospective trials, you can't do them. Okay? So it's never been shown to improve mortality. Having said that, I would like you to sort of look at it as a treatment option to buy time. Okay? So if someone has sepsis, someone has MI, with cardiogenic shock, someone has pneumonia, all it's doing for you is allowing you to oxygenate and ventilate the patient until those antibiotics, until those diuretics, until that stunned myocardium gets better. And that's all it does. No more, no less. Okay?
But if that was not the deadline, the patient would have died. So can you say that it has affected the mortality of the patient?
Well, you can. It's all, but you're inferring, okay? Because someone would say, well, they would have lived anyways, or they would have died anyways. You hear that term all the time. They would have lived anyways, they would have died anyways. So the only way to do that is to randomize, right? Okay, but we can't do that. So I just want you to understand that concept. Okay, in case a family asks you, well, is he going to live now because he's on the ventilator? And you can say, I can't tell you that, can't guarantee you that, because we don't have studies that show that. I can tell you that sometimes it does buy us time. And even though someone's on a ventilator, they can still pass away while on a ventilator. You need to let the family know that. Okay? It's not the cure-all. So just keep that in mind. Okay? I know we all feel really good once we get them intubated on a ventilator, stable, okay? But it's just begun. It's just begun, because now you're going to get questions about what? When are they coming off the ventilator, right? That's what everyone wants to know as soon as they get intubated, right? When are they coming off? So you've got to be able to answer those questions in a reasonable fashion. And you can only do that if someone talks to you and tells you about these things. So you don't have some type of misconception and unfounded expectations. Okay? All right. Does everyone understand this so far? Pressure cycled ventilation is another mode of ventilation that controls the pressure. You can set the pressure above which the machine will not go. The pressure within the airway system. So you set a drive pressure and then you add the PEEP to that. Okay? And those two pressures you add, and that gives you the total pressure. So if you want to add a drive pressure, meaning the amount of pressure that it's used to push in the air, the oxygen, with the PEEP, above that pressure it will not go. What you don't have control over is the volume. And that is determined, again, by the underlying pathophysiology. Whether it may be the underlying chronic physiology of the patient, COPD, restrictive lung disease, and on top of that pneumonia or reactive airway disease, doesn't matter. You have no control over the volume. Therefore, you've got to be very careful. You can't start someone on pressure cycled ventilation and walk away from the ventilator. You better make sure that they're ventilating, because that's what the volume will do. You could not give them enough volume, and therefore you're going to be having CO2s come back at 90, 100, 120. So you have to just understand when to use this mode. Now, we're sort of getting away from this mode. I have not used it in many years. Dr. Crossland still uses it, and I think it's indicated. There are some other things that we can do, such as APRV, which I like to go to, and we'll explain why later on when we discuss PEEP and auto PEEP, okay? I just don't want to confuse the issues. Is everyone okay with this classification? I just want you to have a general, broad understanding so that when you're talking about artificial ventilation, mechanical ventilation, you have it in front of you. Okay. All right. So, yes.
Taking off the advantage because
It's clicking?
Yeah.
Okay. All right. Thank you for that. All right. Again, we're going to talk about a little bit of physiology, but it's just very basic so that you understand how things work within the airway. And you'll find that in mechanical ventilation, a lot of the physiology is related to gradients, to pressures, change in gradients, change in pressures. If you understand how that occurs, when it occurs, again, it will help you understand when you're making a change on the ventilator. So if you decide that you want to follow a patient on a ventilator and you want to decide that you want to make some changes, you don't have to write it on the progress note itself. Write it on another note and show it to your attending to see if this is what I want to do today. I want to increase the PEEP today. But don't just say I want to increase the PEEP. Say it for what reason. Why is it that you want to increase the PEEP? Why is it that you want to increase the tidal volume? Why is it that you want to increase the rate or decrease the tidal volume or increase the pressure support or switch over to SIMV from assist control? You must have a reason. The only way to understand the reasons is to understand the physiology. So with that, you'll see this diagram quite often. This is the alveolus, the airway, and opening upper airway mouth. Okay? So, as you're sitting there again, looking at me, watching me, listening to me, you're all breathing spontaneously. And that's one reason why I say the only thing spontaneous in pulmonary medicine should be breathing, right? So things like spontaneous pneumothorax and so forth are really misnomers, because there is a reason that the patient developed pneumothorax. You just have to go and find out what. So never say this is idiopathic, spontaneous. Only thing that you want spontaneous in pulmonary is breathing. Okay? That's a good thing. So, you're breathing right now because when you take a deep breath, there are signals that are sent down to the muscles that we talked about, including the diaphragm, which then contract, okay, moving the chest wall out and down, creating a negative pressure in the pleural space. The pleural space is nothing like other than an iron lung, right? It's creating a negative pressure, then allowing for what? The pressure here is decreased because it's reflected to what's ever proximal to it, whatever is next to it. So the pressure here is going to be less than here. Okay? And this is really a conductive pressure going through the airway. All right? And so it's called pulmonary trans airway pressure. Okay? It's the pressure that allows for air movement within the conducting tube. All right? Does that make sense? Okay. Using the same diagram, okay, there is another pressure that's called the pulmonary sorry. The pulmonary transrespiratory pressure. That's the gradient, the pressure that creates a gradient between the opening, the airway, to the body's surface. Okay? So if you were able to measure the pressure here, from here to here, the pressure gradient is going to go in this direction. And it's the pressure that's required to overcome not only the resistance within the airway, but the elastance of the chest wall and the lung. And there's where the concept of elastance comes. Does anyone understand what elastance is? What's the definition of elastance?
It's the ability to go back to the same point.
Very close. I like that. Very good. So it's the tendency of any object to return to its natural state. So here's an example. They always use this. A tennis ball and a golf ball. Which is more elastic? Which has more elastance? The golf ball or the tennis ball? It's the golf ball. Why? Well, the golf ball, if you understand, is made of just rubber bands that are 1,000 times wound together, okay? And if you actually take a video of a golf ball that's being hit, it changes shape. It becomes oblong once it's hit. We don't see it, but it changes shape, and then when it hits the ground, it comes right back to its normal shape. And the tendency is much greater with the golf ball than it is with the tennis ball. So this is the lung. The elastance is very important because, one, it keeps the lung in its natural shape and natural position so that it doesn't affect the positions of the muscles, in particular the diaphragm. Okay? So when you have emphysema, what happens is that elastance goes, right? You're destroying the elasticity of the lung. Therefore, the lungs expand. They become more compliant. And we'll talk about that in a little bit, the definition of compliance. And what happens is they begin to push down the diaphragm. And the diaphragms are no longer in the correct position, the optimal position to contract. And I use this example. There's a Starling curve, not just for the myocardium, but also for the diaphragm. So if you push down the diaphragm, those myofibrils begin to stretch, and they're not in an optimal position. Okay? And there's where patients begin to have respiratory insufficiency, not only because of the destruction of their lung, but because of the mechanics. They can't ventilate. And that's another reason why CO2 goes up in patients who have severe COPD/emphysema. And there's where BiPAP and CPAP help these patients, because you allow for those muscles to rest, to come closer, so they have optimal position to contract. Okay? All right. So the pulmonary respiratory pressure is that pressure that's measured, the gradient between the airway opening, our mouth, and the body surface. And it's the pressure that allows for insufflation, for the pressure to overcome the resistance, and we're going to talk about what resistance is, and the elastance of the alveoli and the chest wall. There's a third gradient. It's called the transpleural pressure. And it's the pressure difference between the alveolus and the pleural space. Okay? This is what the different modes of mechanical ventilation work on. Okay? This is what they do. They insufflate, okay, with positive pressure, the alveolus. Okay? Whether there's positive pressure or negative pressure within the pleural space. So you need to understand that concept, because all of the positive pressure works on this. Okay? That we add, the positive pressure that we add to the system. Does that make sense? I want you to understand these concepts because they're going to be helpful in understanding pressure gradients. There are 3 different gradients here, okay? One, from the opening airway to the alveolus, which allows for passage of air just through the conducting system, overcoming any resistance, okay? The second one, from the opening airway to the body surface, which helps you overcome the elastance, okay, and also the resistance. And the third is pressure gradient between the alveolus and the pleural space. Okay? Good. All right, let's move on. And we're going to do Okay, this is a diagram. It's plotted pressure over time, okay? And it's a diagram of a breath. Could be your breath, could be your breath, could be anybody's breath, okay? And it can be done in someone who's ventilated and someone who's not ventilated, all right? So as I mentioned to you, there are two components to taking an inspiration and a total breath.
Just the mic.
Sorry. All right. Thank you. So in a full breath, it's divided into two parts. One is inspiration, the second is expiration. Inspiration is an active process, okay? Expiration should be passive, okay? But in some of our patients, as you know, it's not passive, it's active, especially in our COPD emphysema patients. And that's one reason why most of these patients are like this. They're thin. They've lost weight. Their sternocleidomastoid muscles are really developed. Why? Because they spend their whole life breathing. That's all they do is focus on breathing. So I want you to understand that. Under the curve, the area under the curve is the tidal volume. And that's a known entity because you set the tidal volume. You know, right, what the tidal volume is. But here's where we're going to discuss, this area right here we're going to discuss because I want you to understand the concept, okay? So when we take a deep breath, or when the patient receives, I should say, on the mechanical ventilator, an inspiratory phase, air is pushed in with a certain volume, which is this volume. It reaches a point where the pressure rises, 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 and then above which doesn't rise anymore. And it's a function of the physiology of the airway and the compliance of the lung, okay? And it's called the peak inspiratory pressure, okay? Or PIP. It's an active process. It's a pressure that's measured during air movement, while air is moving within the system. Important to remember that, okay? After the peak inspiratory pressure, there is a fraction of a second, some greater than others, where there is no air movement, okay? And the chest wall, the lungs themselves, the diaphragm, are motionless. Okay? And a pressure is measured at that moment, at that very moment when there is no air movement. And that is called the plateau pressure. Plateau meaning it plateaued, meaning it didn't go any higher, it came down and just plateaued off. And that's why it's called plateau pressure, but it's a pressure that's measured within the system during no air movement. Is that clear? Okay. After which, on expiration, the air is emptied out. Okay? So, what is important about this? Well, the difference between the peak inspiratory pressure and plateau pressure we're going to talk about later, but really measures the resistance in the airway. And that's why I put PTA. PTA is what? The trans airway pressure that I talked to you about before, right? It's that first one, the gradient that's created between the opening and the alveolus. This is the PTA. And it's that pressure that's needed to push air through the conducting airway. Okay? So just keep that in mind. So, we talked about elastance. We're going to talk about compliance now. What's compliance? Does anyone know the definition of compliance?
Compliance is actually is easily to fill something means higher compliance. And if you give a little pressure and you will get high volume, that this is high compliance.
Okay, well, you said it. You said it in your own words, but it's correct. So what it means is any change in volume, okay, over a change in pressure. And how you would translate that is, for any given pressure, and we measure pressure in sonometers of water pressure, okay, there's going to be a concomitant change in volume, okay? It's going to be a concomitant change in volume. Now, there is a Dr. Lim can help me on this. He's more advanced than I am about these things, but this whole concept of compliance really kind of falls under Boyle's law, and I think some of you might remember from your chemistry or physics or whenever, that there's an inverse relationship between volume and pressure for a given temperature. I should put that down. Okay? It's a constant. The product of these two is equal to a constant. So basically what we're saying is, as volume decreases, what happens to...
Pressure.
Okay. So you can use that in the same text, same concept of lung volumes and peak inspiratory pressures. And we'll see that a little bit later. Okay? So I'm going to erase this because I need a little bit of space. Compliance is therefore the change in volume over a change in pressure. There are two types of compliances. One is static compliance. Static meaning from the Latin word stare, firm, to stay, no movement. No movement. So what did we talk about? No movement. Well, plateau pressure is a pressure where there's no movement. So you want to subtract any additional pressure. So normally most patients are on some type of PEEP. That's an external pressure, an artificial pressure that we added, so you must subtract it from what's going on within the lung. So, I'm sorry. If you want to be very correct, you could measure the tidal volume that's set on the ventilator and then measure the volume that's exhaled. Okay, you would need an apparatus to do that, but for all practical purposes, you can use just the set tidal volume that you've set on the ventilator, because this is technically the change in volume. So you need to know the change in volume on inspiration and expiration. But that becomes a little bit difficult. You can look at the machine and calculate and see when they exhale. I just average it out and usually just use the tidal volume that's set. Okay? So this is static compliance. The tidal volume, change in volume over the change in pressure, and because it's static, meaning it's not moving, you've got to use the pressure that's measured during no air movement in the system. Does that make sense? Okay. The other type of compliance is dynamic compliance. And again, because it's dynamic, meaning there's air movement, it's the pressure measured during air movement, it's the tidal volume over the peak inspiratory pressure minus any added pressure that we add to the system, PEEP. Okay? So you're looking at me, and I don't blame you. and say, well, who cares? And I can write this down and keep it in my pocket. And I know the definition if they ask me on the boards, which they won't. So what you have to ask me and what you have to be thinking is why is he telling us this? How am I going to use these pressures to manage patients? Because that's the bottom line, right? That's the bottom line, okay? My chairman used to tell me, Lewis, boards are important because you got to pass them, okay? But what's really important is that on a daily basis you know how to take care of patients, okay? And that's true, and it's very true. So how can we apply this concept to everyday management of a ventilator? So let's take an example, okay? So you've got Ali who admits a patient overnight and with an anterior wall MI. This is a classic example. Large anterior wall MI. Remember what I told you at the beginning of the lecture. I want you to always take into consideration when you have someone on a ventilator, why did they get intubated? What kind of physiology they may have, either chronic or acute. Okay? So they have an anterior wall MI, they get intubated, they have some pulmonary edema, congestive heart failure, and they get intubated. Okay? So several hours go by. Ali gets a call from the ICU nurse saying, Mr. So-and-so has just desaturated on a ventilator. Sats went down into the low 80s, high 70s. Okay, so kind of a nightmare. You're desaturating on a ventilator. Not a good thing, right? So Ali, as a good resident, goes down, sees the patient, examines the patient, gets a chest x-ray, and also notes that now this patient has a loud apical murmur, reading all the way to the axilla. Okay? Huge jugular venous distension. Okay? Gets a chest x-ray, but says to the resident, or excuse me, to the respiratory therapist, could you do me a favor and calculate the static and dynamic compliance? Okay? Because when we're looking at static compliance and dynamic compliance, just so that you understand the kind of normal ranges, static compliance ranges from anywhere from 70 to 100 mLs for every centimeter of water pressure. That's normal. Okay? That's normal. Dynamic compliance is about 40 to 70 mLs. Okay? Is that clear? Okay. So, respiratory therapist comes back to Ali and says, well, Dr. Bondel, here's the thing. Patient came in and pretty much the dynamic compliance was about 60, and it's still about that right now. But the static compliance when the patient came in was 70, and now it's down to 30.
Loss of volume.
So where's the lesion? Where's the problem?
Pulmonary edema.
Well, why? Ali says pulmonary edema, you're correct, but why?
Loss of volume because you're telling me the static is now down. That means the lung lost the tidal volume.
But lost volume, meaning, but why is it the volume? What is the static compliance telling you? It's measuring the compliance of the lung during no air movement. So where is there no air movement? There's no air movement in the interstitium, right? There's no air that goes in and out of this. So it's an interstitial problem. Pulmonary edema is an interstitial problem, right? It's not an airway problem, right? Does that make sense? This can apply for ARDS. It can apply for bilateral pneumonia, worsening pneumonia, pneumococcal pneumonia. But any restrictive process, any process that's going to affect alveoli but also interstitium. Okay? So let's try one more. young man, and this actually happened. This is a true case. Happened here years ago. 25, seizure disorder, gets intubated to protect the airway. Sent to the ICU. Middle of the night, desaturates, resident is called. Okay? So, a few hours later after admission, patient desaturates down into the 80s, and the resident's call goes down and examines the patient, sees that the peak airway pressures are going up, the sats are in the 80s, and so the resident actually astutely said, can you measure for me the static and the dynamic compliance? And so they do a chest x-ray, it's completely clear. An exam, good air entry, clear. They measure the two compliances, both were normal at the time of intubation, and your respiratory therapist should be calculating them at the time of intubation. And when they repeat the compliances, the static is normal, and the dynamic now has gone down to about 30. So where's the lesion? Where's the problem?
Airways.
So it's an airway problem. X-ray's normal. Good air entry. Clear. So where is it?
There was increased peak inspiratory.
It's right. It's an airway, but I want you to think now, this is a patient who's seized. This is a patient who bit on a tube, bit on the ET tube. That's part of the airway now. Okay? There's where the lesion was. It was kinked. And so the dynamic compliance went down. It's an airway problem, nothing else. It does not lie. Okay? It does not lie. Okay? So if you had someone with pulmonary hypertension and acute pulmonary embolism, what would the compliances do? They would be normal, because it's neither an airway problem, it's neither alveolar interstitial problem, it's a vascular problem. So these are the kinds of things that I want you to understand in terms of concepts so that you can apply them to everyday management of a ventilator. This is really troubleshooting part of it, okay? Troubleshooting, figuring out where the problem is, okay? Is this clear so far? Is this clear? Okay.
One question.
Yes.
The compliance, the systolic and the static and the dynamic. It's calculated on the machine, or
Yeah. When I trained, we had to calculate it ourselves based on. They all had, the older machines had a tube that came out of the machine during exhalation, and then what you would do on an expiration is put your hand underneath it to close the system, and then we would look at the gauge, and it would tell us what the pressure was. Well, now everything is digitalized, and so all you need to do is they can calculate it for you very quickly. Just like now they can calculate auto PEEP and all these different things for you. It's very simple. It's not difficult at all. Okay? So these are some of the basic physiology, basic concepts, gradients, definitions, classification. Okay?
And Dr. Babu, sorry, I apologize. This works, the same concept works with every type and modality of ventilation. Is it the same for every modality?
No. Well, this wouldn't work for negative pressure ventilation, right?
No, I mean...
Right.
Well,
For positive pressure, right. For positive pressure, right.
Okay.
Absolutely. Even for volume cycled or pressure cycled, absolutely. Absolutely. Concept doesn't change, right. Okay. So now let's get into something a little bit more maybe interesting to you, so we'll clarify some things. So when it was clear that medicine needed to move on and come up with a better solution for patients who had respiratory insufficiency involving the lung itself that wasn't necessarily a neuromuscular problem. They came up with this whole concept of invasive positive pressure that we just discussed. But they all had to come to an agreement as to how they were going to design these machines and what the physician managing the ventilator was going to have control. Okay, what part? What could they control, what they couldn't control? So obviously they had to come up with what we call modes of ventilation. Okay. Does anyone know what it means, mode of ventilation or modes of ventilation? It's an important concept. I want you to understand it. I never understood it for such a long time until one day it kind of clicked. I finally understood it. So I want you to understand and I want you to realize that a mode of ventilation, okay, describes the interaction that the physician sets between the ventilator and the patient. It's a relationship that you create. Isn't that beautiful? I mean, it's how poetic can that be? What other discipline does that? You're creating a relationship between the ventilator and the patient. And I know it sounds funny, but you're going to see that that's what you're doing when you're talking about assist control and SIMV and all these terms and right that we never really think about. But that's what you're doing. You're working on how best does this machine interact, or vice versa, this patient interact with this machine. And how are you going to do that? Well, you first need to understand these concepts that we just discussed. Once you understand these concepts, then you're going to understand your patient. Remember I kept saying, understand what kind of physiology that patient has. Why were they intubated? What's going on? How are they changing from day to day based on your treatment? What diagnosis have you made? Is it the correct diagnosis? Do I need to revisit that diagnosis? Okay? So when they started out, they said, well, we obviously have to have control of the FiO2, right? The partial pressure of oxygen. We have to know that we can give 100%, that we can give 50%, that we can give 30%. We have to do that. So they said, okay. Then they said, well, we want to have control. Well, before that, they said, we want to have control of the tidal volume. I got to know that because based on someone's size, someone who's small may require a lesser tidal volume. Someone who's bigger may require a higher tidal volume. I said, fine. And then the last was the rate, because the rate times the tidal volume gives you the minute ventilation. So they wanted to have control of that. So basically, if you look at this, okay, this graph that I'm going to describe to you, what the machine would do is it would give inspiration, expiration, okay, these breaths. These are all machine breaths. And under the curve, the area under the curve is the tidal volume. And there's the frequency, and then the FiO2 is applied. And this was great, you know, wow. This machine gives positive pressure with a certain tidal volume, certain FiO2, certain rate. Beautiful, okay? Problem is, this really worked well when your patient was knocked out. Either they were sedated, they were under an anesthetic, they were in coma, and they really required complete support from the ventilator, okay? And what they found was that when the patient woke up, what did they start doing?
get agitated and fight
Well,
the machine.
they start taking their own breaths, right? Well, you can imagine the problem. Machine breath, machine breath, machine breath, patient's own breath plus the machine breath. And if you ever felt that, you should. The respiratory therapist will let you do it. They'll have you hooked up to a ventilator, just put the tubing in your mouth, and then you can feel when you take a breath, and they'll give you a machine breath, boy, you're just inflated like a balloon, and then you're not synchronized, and so you're trying to breathe out, and it's giving you another breath. And so what would occur is they would see these patients what they called bucking the vent. Eyes bulging, pressure initially going up, face gets red, and they're trying to get out. They're trying to pull this thing out, try to get out. So obviously they said, wait a minute, this isn't working completely the way we want it to work. And what they called this mode of ventilation was controlled ventilation. Does that make sense? Okay. So they went back to the drawing board and they said, look, we've got to come up with a better system. And so they said, we like to have control of the FiO2, the tidal volume, and the rate. But what we want to do is this. Have the machine give its breaths as they're set, either 12 per minute, 14 per minute, 16 per minute, 10 per minute, whatever you want. But if the patient should take their own breath, what we want the machine to do is sense the negative pressure, because that's what the patient creates, right? That little negative pressure, and then resets itself and gives another breath. So it would allow the patient to initiate their own breath, but at the same time then reset itself, so there's less bucking, okay? There's more synchronization with the patient as they wake up, as they become more conscious, as they take more spontaneous breaths. And so what the machine was doing is saying, look, Dr. Lovett has guaranteed you 12 breaths per minute. But if you should decide that you want to take a couple more on your own, we're going to let you do it. We're very democratic here. We're going to let you do it. Okay? And without interfering with the machine, I will reset myself back to the 12 per minute. And so they decided to call this mode assist control, right? So you have control over the FiO2, tidal volume, and rate, but that mode also assists the patient. So if they want to take their own breath, it allows it to do it. And then supplies the oxygen. Does that make sense? Okay. Well, this was fine, and people liked it, and there are pulmonologists to this day who just use assist control. Two of them in this hospital, Dr. Macanjola, Dr. Crossland, just use assist control. They don't really go to any other mode unless it might be pressure cycled or something like that, and I've seen them on occasion go to APRV. You can't fault them. The literature is very clear. It's okay. There's no one mode has been shown to be superior in survival or weaning, extubation, than another. So you can't fault them. And so it's okay. Okay? But some physicians said, my patient, comes out of the OR, they've got their abdomen splayed open, they got a mesh, they got protein malnutrition, they're weak, but yet they're waking up. and they're taking more and more breaths on their own, and it's been a couple of weeks, and I don't want to do a trach. I really want to try to see if I can get this patient off, but I don't want to just try to do it just on assist control by decreasing their rate. I want to help them out a little bit more. I want to see how much can they do on their own. I just want to know. So they said, well, let's think about this. We're going to stay with the FiO2, stay with the tidal volume, stay with that rate that we can have control over. But what we're going to do is allow so that this new mode of ventilation will give machine breaths, whatever they're set at, 12, 14, 16. But when the patient decides to take their own breath, that machine is going to say, okay, you decided to take your own breath, I sense that negative pressure, come and get the oxygen yourself. I want to see how much you can do. So that patient has to take that inspiratory effort sometimes starts getting bigger because they have to suck in more oxygen, and you understand that if that's the patient who's intubated, they've got to open up a valve here, and they've got to suck the air out through this dead space ventilation, right? This is just a tube that's not exchanged with any blood vessels, so it's all dead space ventilation. They have to take it all in, right? Themselves. That's what the machine is set to do. And so the volume changes. It's no longer the machine volume. It's a smaller volume. Therefore, what's going to change on a blood gas? The ventilation, the CO2 may go up. Okay? So they said, well, you know, I kind of like this concept. I kind of like it. And so what they decided to call it was SIMV, which stands for synchronized, because it's synchronized with the patient as long as they want, and even if they take their own breath, it resets itself like assist control. Mandatory, meaning it's mandated to reset itself and give the same tidal volume with the same oxygen and the same rate. Ventilation. The only difference is that when the patient takes their own breath, it's truly their own breath. Okay? So, they liked this mode, made sense. And again, this mode has never been shown to be superior to the other modes. I just want you to know that. It's really more of a style. I tend to use it. That's how I was trained. I kind of like it. Makes sense to me. But these scientists that came up with this idea said, you know, we really don't want to be cruel to these patients, because we do have to understand that they're patients who are weakened by either their surgery, by protein malnutrition, they're on sedation, they're in pain. So what can we do to help them with this? And so they decided to add another pressure to this mode, which is called pressure support. Okay? So that's why when you have someone on SIMV, okay, you can add pressure support. But you must understand that pressure support only is applied during the respiratory cycle when the patient takes their own breath. So even if you have someone on SIMV, but they're not taking their own breath, it's still assist control. Therefore, you can add pressure support to 20, to 30, 35. They're not using it. So I tend to use assist control when patients are sedated or they're in comatose, they're under anesthetic, or they're paralyzed, especially if they're paralyzed, you have to give them assist control because they can't take a spontaneous breath. And trust me, there have been mistakes with that, okay, because some people don't understand the concept between assist control and SIMV, okay. Although if you put them on SIMV, it's still assist control because you set a rate and they're not going to take, if they don't take their own breath, it doesn't kick in, okay? But it doesn't look that good. You know, if you put someone who's can't take their own breaths and they're, excuse me, and you have them on SIMV, it's pretty clear that you don't understand how the two differ, okay? So I want you to understand that. So pressure support is an added pressure applied by the machine, set by you, to overcome the resistance within the airway. So what it does is it decreases work of breathing. It improves ventilation. It does not, I repeat, does not recruit alveoli. It does not improve oxygenation. It improves ventilation. It decreases work of breathing. In fact, if you have someone fully awake on the ventilator, you put them on SIMV, I sometimes talk to the patient and just increase the pressure support, okay, and ask them, how do you feel? And does this feel better? Does this feel better? And they'll tell you. They'll be able to indicate to you what they like, okay? Now, the question is, when you're using pressure support, okay, what number, what level of pressure support should you use? Well, this is where it's important to understand why you use pressure support. And I said you use it when patients are taking their own breaths, usually in an SIMV mode, and you want to give it to them to decrease the resistance, i.e. work of breathing. So what you need to know is, what's the definition of resistance? So it's the change in pressure over flow, right? Right? We see it. When else do we see it? Our cardiologists see it all the time. Resistance. They're always calculating resistance. Where do they calculate resistance? So, systemic vascular resistance. How do we calculate that?
Mean arterial pressure
Right.
divided by cardiac.
Well, it's something else. What else? Mean arterial pressure.
Minus right atrial pressure.
Right. CVP over what?
Cardiac output.
Good. Okay. PVR. Pulmonary arterial pressure minus pulmonary capillary wedge pressure over cardiac output, which is the flow, right? Same concept. So how do we do it in the lungs? What pressures do we have? What did we talk about? We have the peak inspiratory pressure, right? I'm going to do this over here because I think I'm just losing, I don't know that everyone can see this. Peak inspiratory pressure minus the plateau pressure over the flow liters per minute. We're going to go through all of the settings later, but one thing that you don't necessarily set, I look at it, but usually the respiratory therapist will set it. You can set the speed with which the oxygen is delivered, which is the flow. And usually it will go from anywhere from 40 liters per minute to 100. I know you don't pay attention to that, but if you look into that green book where they give you the settings, you'll see flow, and they'll put it either 0.6 or whatever, 1.00, 100, whatever it may be, okay? And that's where the flow comes. So if this is the resistance, all you would need to do is calculate the resistance for every individual patient by getting the peak inspiratory pressure, subtract it from the patient's plateau pressure, and the flow is given to you, right? So if pressure support is used to overcome the resistance, if the resistance is 10 liters per minute, then your pressure support is going to be 10. And what did I say? About that pressure time volume, pressure time graph. Peak inspiratory pressure, plateau pressure, and the trans airway pressure, right? And what did I say that was? That was the first diagram, the gradient, opening pressure, the pressure gradient between the opening airway and the alveolus. It was the pressure needed to what? Overcome the resistance. Okay? Does this make sense? Because I'm looking at some of you, I'm not sure if it does or not. I know it's a lot of information, and I know it's something maybe that you're seeing for the first time. But we can review this again briefly on Thursday before we move on to some of the other concepts. And I have for you on Thursday also a little quiz that we'll do together. It's not a test, but it's really for you, about 5 or 6 questions that will review this again, make you go through all of this.
So, Dr. Love, so the difference between the peak inspiratory pressure and the plateau, that's the resistance?
Right. The difference between the two, okay, over the flow will give you the resistance. And I said that earlier to you, that the difference between the two is going to give you the resistance. Okay? I want you to remember the formula for the resistance. So resistance is equal to change in pressure over the flow. We use that in circuits, we use that in cardiology, PVR, SVR, it's the same thing. The concept is that. Okay? So I'm just trying for you to understand the concept of pressure support and why we use it and how you can calculate it. Just like later on Thursday, when we talk about PEEP, you want to know what is the optimal PEEP pressure that you apply. Well, I'm going to show you what the optimal PEEP pressure is and how you figure that out. Okay? The concepts are basic. They're new to you, to some of you maybe, but you can get them and absorb them. The article that I gave you on mechanical ventilation goes over them in a basic format. Mohammed?
Can I ask a question?
Even two.
This graph is interesting. I mean, this equation and graph, does it mean that if the plateau pressure is equal to peak inspiratory pressure, there won't be any resistance?
Yes, right.
So,
Technically, yes.
so if
That won't happen, but that won't happen because these patients who are on ventilators have some type of turbulent flow. Flow isn't completely laminar. It's turbulent, okay? So therefore, there's going to be some reactivity of the airway, is going to be some narrowing, most of these patients. But in an ideal situation, yeah, absolutely, yeah.
I mean to say that the PSP.
But I don't know that there's anything that's without resistance, complete resistance.
Right. Yeah. So actually, I meant to say, you're right, but I meant to say that the PSP trial, if we give like 10 to work on the resistance of 10, so it means
That's a pressure that's applied during inspiration that helps the patient overcome any intrinsic resistance that they have. And I'm just showing you how to calculate it.
yeah, right.
Because someone will say, well, what's the optimal pressure support? Well, ideally, it's the pressure support that's going to allow the patient to feel comfortable and decrease their work of breathing so they have normal ventilation. Well, that's fine, that's all words. But what's the number? Because that's the bottom line. What's the number? Because the respiratory therapist is always going to do this to you. They love to do this, and they'll go, what pressure support do you want? Right? They always do that. Well, what pressure support do you want? You know?
I don't know.
So my answer to them is always, well, it's based on the resistance. Then they start backing off, okay, because they go, uh-oh, okay. Yes?
Let's say the condition we have pressure support of 10 and EPO 5.
Right.
So the difference would be the 5 would be for the
Right.
airways, to overcome the airways, right?
Right, but when is PEEP applied? I didn't want to get into this, but we're going to now since, when is PEEP applied?
Whether it's
At the end of expiration, so there's no air movement, okay? So it's still incorporated within plateau pressure.
So Dr. Levitt, does this mean
So it's insignificant. What?
nothing to do with the resistance, right?
What doesn't have?
PEEP has nothing to
No.
do with the
Because at the end,
resistance.
Completely different concept, and that's why I'm separating it. I'm not discussing it. I know you have to ask me questions. That's fine. I just don't want you to get confused because that's why it's a separate article and it's a separate concept. And I want you to understand the concept because it's going to come up. Even auto PEEP is going to come up. And I can't tell you the number of times that, you know, in the 15 years I've been here, you know, walking through the ICU, you know, people ask me questions about patients on ventilators, even though they're not my patients, you know, they may be bucking the vent. And one of the things I do, you know, when you just look at the patient, you can kind of tell what's going on. So I just say, just calculate for me the auto PEEP. And this just happened last year. You know, auto PEEP was 15. And so I said, well, we just have to increase the PEEP. So I increased the PEEP, melted away, and I'm going to explain to you why on Thursday. So you don't, what I'm really trying to do again is underline the term that I used earlier, and that is demystify mechanical ventilation. You know, I never understood when I was a student, when I was a resident in particular, that it was such a secret, this box that provided oxygen. Why is it that no one will teach me how this thing works? Not even pulmonary specialists could teach me how this thing works. So I never understood is it a secret? Do you have to be part of a club? What is this thing? So I just decided to put this lecture together because I didn't want you to have to go through what I went through. I mean, I still remember the day that my first day in the ICU, I had just finished internal medicine, and I'm in an inner city hospital in Hartford, very sick patients, and I walk in to an ICU room and there's a nurse and she rattles off, patient is in this mode, FiO2 of this, PEEP of that, pressure support of this, what do you want to do? And I just stood there like a dummy. I mean, I had no idea, never heard of it, never understood it, never knew what it meant. Deferred to my resident, went through the whole ICU rotation. To save my life, I still could not manage a ventilator. Had someone put a gun to my head and said, make the right decision here in this ventilator, you might as well shoot me, because I had no idea what I was doing. And nobody could really explain it to me, okay? And I think part of it is because we assume things, we assume that you understand basic concepts. You can't assume. If you think everyone knows these concepts, you think twice. I don't go home, well, that's not true, but most people don't go home thinking of the pressure is this and the pressure is that, and so forth and so on. Now, I go around and I've told my residents this, that I do look at fingernails and I do look at cyanosis and patients, and I just do this when I'm in the airport because that's what I do. I just do that. My wife leaves me alone. She knows that I do that and that kind of thing. But I don't expect you to think about pressure support and assist control and all these other things. But if someone can get your attention and say, oh my God, I didn't know that. I didn't know that that's how it works. Wow, I like this. I can kind of figure this out. This makes sense. This makes perfect sense. Okay? And I had a group of residents in April who admitted a patient overnight who had high peak airway pressures. They went ahead and calculated the auto PEEP. They realized the patient had high auto PEEP. Patient was wheezing, actually had a bronchiolitis, had pops and squeaks, and they knew what to do, and they wrote the right orders to increase the PEEP. But someone, a respiratory therapist, said, no, and they went up on the rate, which will worsen auto PEEP. But I was very proud of the residents who made those changes because they had heard this lecture, they understood the concept. Patient ended up having H-flu, pneumonia with bronchiolitis, and with COPD. So it was a beautiful case, and Thursday you'll understand what I'm talking about right now. Well, they got turned on about this, and so they felt really good about themselves, and I felt good for them. And that's all I want you to do. I'm not asking you to become a pulmonologist, but it will help later on if you're taking care of a patient, whether you're managing the ventilator or not, to be able to go to the family and say, this is what's going on with the ventilator. This is what the doctor's trying to do. These are the things that we're trying to accomplish based on the diagnosis. To have a basic concept of something is okay. And the only way you're going to do it is if someone walks you through it.
Dr. Lavin.
Yes.
This formula obviously is a very nice formula because in our stay, for example, in ICU, for the last one, what we used to do was just, for example, start with a pressure support of 60 and
Right.
see that patient and decrease it to 14, while looking at his oxygenation and so on.
Right.
So, this makes it more objective. And
Right.
one question I have is this plateau pressure,
Mhm.
do we get it on the machine? Because
Yeah, yes. They should be able to calculate both dynamic and plateau pressure, and they should write it in the book. I've called them over and said, we don't have a baseline dynamic and plateau pressure. I can already foresee, depending on the patient, that I'm going to need this, if they go into ARDS and this kind of stuff. Some patients, it won't matter because you're going to be able to extubate them without it. But there are some I say I need to have a baseline because later I'm going to ask you to redo it. And if we don't have a baseline, I don't know if this is worse, the same, better. I have no idea. Okay. Go ahead.
From my understanding is in assist control when the patient, it allows the patient to initiate a breath, and if the patient initiates, it will deliver the preset tidal volume.
Preset tidal volume, yes.
SIMV,
And go back to the rate.
Okay. And
Reset.
SIMV, if the patient initiates a breath, it will allow the patient to take the breath, but it will not deliver.
Not deliver it. Come and get it. Here it is. It's on a platter. Come and get it. Okay? So there's where the pressure support comes in to help.
So does that mean if my patient is improving, do I want to take him from AC, maybe put him on SIMV, or it doesn't work that way?
It does. It does. It depends on your training. Who influenced you in your training? I have an individual who influenced me and taught me how to manage ventilators, Dr. Lahiri, and I manage ventilators like he manages ventilators. That's how I learned. That's how I feel comfortable with. However, there are physicians in this hospital that just stick with assist control. You cannot fault them based on the literature because the literature is clear. It says, look, we did a head-to-head trial. There you can do a head-to-head trial. There was no difference. There was no difference. Okay? Now, I can tell you this, when you're doing SIMV, and you get down and you decrease the rate finally to the point where you put 0 rate, that's called continuous positive airway pressure, CPAP, right? Pressure support. They're only getting a drive pressure, the tidal volume, and they're only getting pressure support, right? Their rate is spontaneous. It's on their own, right? If the literature is clear that if they do well on CPAP of 7, that is a pressure support of 7 or less, they should extubate and do well. That's the literature when it comes to that. However, the literature is also clear that when you look at two modes, AC or SIMV, neither one is superior over the other in extubation or weaning and extubation. Okay? It's really a style that you feel. My feeling is I kind of like to know what the patient does because if I put them on SIMV and pressure support, sometimes I can pick up a paradoxical breathing that I wouldn't on assist control. And have I proven that that is clinically what happens to every? No, I haven't. They're all, but you can't. It's hard to can't randomize some to none and can't do that. So.
Dr. Lockett, why PSP is called CPAP?
I'm sorry?
Why PSP trial PSP pressure support is also called CPAP?
Because a CPAP is just a continuous positive airway pressure. So when you eliminate the rate, all you're delivering, other than oxygen, is a positive pressure, right? A drive pressure, which is the tidal volume, right?
At 7 or at 10.
Right, and the pressure support.
Right. And is there any difference between volume AC and pressure AC? I have seen ventilators being set at volume AC and pressure AC.
Yeah. The AC just means that they're getting a set rate. Okay. You came in a little later, but I explained this. But we'll no, that's fine. That's okay. I'm gonna go over. No, it's important in the classification of positive airway pressure ventilation. You can go to either non-invasive, which you know as CPAP or BiPAP, or invasive. When you get to invasive, it breaks off into volume cycled, which is the traditional, the ones that you see now for the most part. But those same machines can switch over to pressure cycled. The difference between the two is in volume cycled ventilation, you have control over the volume. You set the volume. You know the tidal volume is 700, it's 600, it's 550, whatever it is. But you don't have control over the pressure in those patients, right? That pressure is determined by their physiology, whether they have COPD, whether they have a restrictive physiology, whether they have reactive airway disease, whether they have pneumonia, whatever. In pressure cycled, that is telling you that you have control over the pressure, beyond which the machine won't go. So you set the pressure based on the drive pressure, which is the tidal volume really, and a PEEP, if you want to add PEEP. So if you say, I don't want this to go over 35, I don't want the peak inspiratory pressure to go over 35, so you go 30 of drive pressure, 5 of PEEP, it won't go over 35. What you don't have control over is the volume. Therefore, you don't have control over the ventilation, and that's why it's important to understand, does this patient have a restrictive physiology? Because if they do, I better increase their rate, because what will happen is that you'll put them on pressure cycled ventilation and their CO2 will come back to you at 100, 120, because you don't know, you have no control over their volume. Does that make sense?
Yeah, most of the part, but in AC mode we also have control over PEEP. We say like 600 tidal, rate of 12, PEEP
Right.
5.
We haven't gotten to PEEP yet.
Oh.
So I want to keep that separate, because if I get into PEEP, then I don't want to lose you. I want you to absorb this and feel good about it. We went through a lot of different things, and I know you're on service and you're on doing nephrology, and I know it's busy. So, but we'll talk about PEEP on Thursday, and I hope you have the two articles that I set out. One is on just basic mechanical ventilation. The other one is on PEEP and auto PEEP. And Thursday we will review a little bit quickly again what we discussed today and get into the concept of PEEP, okay, and troubleshooting, and a little bit about how you set someone up on a ventilator, okay? And then I have some questions for you, and if you pass, You don't have to repeat your internship year. If you don't pass, you have to repeat. Okay? So, but you said you can't make it Thursday, right?
I would.
I was giving you an out. See, I was giving you an out. You know I'm joking. It's just, it's an interactive quiz. We're going to do it together. But it's a quiz that I've designed that reinforces these concepts. Okay, one last time. Any questions, feel free to ask me now. I'm happy to answer. I have a question for all of you, and I want you to be honest because it means a lot to me to know. I try to design my lectures based on what I think is a good way to learn and absorb. That doesn't mean that I succeed. So today, do you feel a little bit better about mechanical ventilation, indifferent, or are you still confused? Anyone want to speak out? The students, the interns in particular?
Yeah, I think much better. We feel much better. I mean,
Does this make sense? Seriously, I don't get offended. I just need to know. Because if there's something that we don't, then on Thursday I'll go over it again to try to clarify the concept.
yeah, Dr. Lavi, probably on top of this, if you include, for example, when to choose pressure support ventilation versus volume and for which people.
Yeah, and I said to set somebody up, we'll talk.
Exactly.
We're going to talk about that. That's not a problem. I don't want to get into that now. I just want you to understand the different gears before you actually go out there and drive the Ferrari, right? You want to know it's got 6 gears.